Hi everybody, we won't be a few minutes, just a few technical issues. We'll be with you shortly, thanks. Hello and welcome to the Greater Manchester Primary and Community Nurse Quarterly Forum. I'm delighted to introduce a number of specialist guest speakers throughout this afternoon's agenda. Today's agenda is a little different than usual in that the second half will be where you'll be directed to breakout rooms in your chosen topic area. Once your session is complete, you'll be once again redirected back into the main room. Can I please remind everyone to mute your microphones during presentation, please? And there will be the opportunity during the sessions for questions to the speakers. I would like to firstly introduce Sheni Rajji Smith. Sheni is our Organisational Development and Leadership Lead at Greater Manchester Health and Social Care Partnership. Thank you, Sheni. Hi, Sheni, is everything okay? I think Sheni must be having some issues with her IT at the moment. We'll just give her a few minutes. Thank you. Sorry, hi everyone. It looks like Sheni's having some difficulties getting into the meeting. So we're going to move up the agenda and we'll come back to Sheni in a minute. So if we go on to Sarah. So Sarah's going to give us a cervical cytology update. Thank you, Sarah.
No problem. Let me just share my screen. Can everyone see that?
Yes, thank you.
Yeah, lovely. So my name is Sarah Jones. I'm Screening Immunisation Coordinator for the Greater Manchester Screening Immunisation team. And also with me today is Richard McCormick, who is an Assistant Coordinator within our team. So I'm just going to give you a bit of an update about cervical screening, how things are at the moment, any changes to the programme, anything that we think you might need to know. If you've got any questions at any point, please pop them in the chat. I can't see the chat until the end, so I'll answer any questions once we finish the presentation. So firstly, I just wanted to say thank you to everyone who's involved in the cervical screening programme. I know it's been really challenging 18 months for primary care. So the fact that you still, and I'll go into this later, doing a huge amount of cervical screening is really great. So thank you very much. So firstly, I'm just going to have a quick look at the uptake in Greater Manchester. So this is comparing December 2019 to December 2020. This is the most recent published data that's available. And as you can see in every area, including across the north in England, the rates have dropped by a couple of percent across the board, which is not anything to be surprised about, really, considering for a good chunk of last year we weren't offering cervical screens. So this is the 25 to 49 cohort, and the target's 80%, but currently in most areas there's a few practices that achieve 80%, but the majority fall between the kind of 70 and 80% mark. If you want to have a look at your own practices data and compare it to other practices within your CCG, you can do by visiting this website, and I'll pop the link in the chat so you can all see it. And that's all published. It should be updated in the next month or two with the most recent data. So it's a similar picture for the older cohorts. Their uptake is generally higher, but again, in every area we've seen a slight dip due to COVID. So as you'll all be well aware, during the lockdown, the samples received by the lab reduced massively. Most practices stopped offering cervical screening because you weren't seeing face-to-face patients. But since September, we've seen a massive increase in samples being submitted to the lab. So this is across the northwest. We're seeing 9,000 to 12,000 each week, and for the last few weeks we're seeing around 100 per week more than what we would normally assume. So that's brilliant. You're seeing more than ever for cervical screening, so that's really good. Some women are still quite hesitant to attend because they might have been shielding during COVID and still concerned about the risks. And Joe's Trust did a really interesting survey around September last year, which showed that some people assumed that screening wouldn't be a priority. They assumed that the practice wouldn't want them to go in for screening because they'd be wasting the time and they've got more important things to deal with. So that's important to bear in mind. If you haven't, I would look back at all the women who didn't attend during COVID last year that were supposed to, and just re-invite them and explain what steps your practice have put in place to reduce any COVID risks, and that screening is a priority and that you would be happy for them to come in. So due to this massive increase in samples, the turnaround time at the lab has gone up a bit. So at the moment, it's up to 42 days. So the majority of samples will be back much quicker than this within the normal 2-week time frame, but some are taking longer. And it's important, if you're a sample taker, just to make sure you're aware of the most up-to-date turnaround time, which is always on the sample taker database, which is a website where you put your training on. So you should make sure that your patients are aware when they have the test taken that it could take up to 5 to 6 weeks for them to come back. And it's important to remember that cervical screening shouldn't be used as a diagnostic test. So if one of your patients does have symptoms that they're concerned about, then they should be referred without waiting for any cervical screening results, because that could delay things. After the 42 days, if you've still not got a result back and you're concerned that the sample might have been lost, then please do contact the lab to check it out. They'll be able to tell you where it's up to. But the lab aren't able to speak to patients directly, so please, if you could contact the lab on your patient's behalf and not give their number out to any members of the public, that would be great. So now I'm just going to pass over to Richard, who leads on looking at rejected samples in our team. So Richard, can I pass it over to you?
Yeah, thanks very much. Yeah, I'm Richard. I'm just going to speak a little bit on rejected samples. So looking at this year and between March and May, we've had 350 rejected samples so far, which obviously is quite a large, well, it's a decently large number, especially for very busy practitioners and sample takers, to have to rearrange all of these appointments. Obviously, once a sample has been rejected, the lab will write to the sample taker, and they'll also give a reason, and that should be getting to the sample taker. So often it can be sort of lost in the admin side, but yes, that should get to the sample taker within a practice. Repeat sample should be carried out 3 calendar months after rejection. Yeah, and we sort of outlined the main reasons for rejection on the left hand side here. Practices should be keeping a list of all samples taken and ensure a result's been returned, obviously for each of them. If you do have any issues or queries or about samples, about when to take samples, and then obviously either contact the lab or ourselves, and the lab contact number is down at the bottom there. So looking at the reasons for rejection. So the main reason is early repeat. So that's probably consistently our highest number of rejections. Out of date vials is quite a solid second place, and I think probably over this last year, with pauses and delays, that maybe there have been more sample pots around than we have had previously. So that's an increase, and then obviously unlabeled vials or problems with labeling. So have the next slide, please. Looking at those 3 main reasons, having sort of chatted to sample takers and sort of getting some information together, we put together a few tips, and I'm sure probably a lot of most of you doing this, but these are some ideas that we got. So early repeats, always checking on Open Exeter. If you're unsure, and to back that up, also the lab will tell you as well. So again, using that number to defend the lab. There is a new Open Exeter coming, and Sarah will give you some more details of this later on in the presentation. So to define samples taken more than 3 calendar months, and that was previously 6 months before an individual's test date, should be considered out of programme if they're a routine recall, an early repeat test in 12 months following HPV, positive cytology or a negative test, or a follow-up test after colposcopy or treatment. Expiry date on vials. So some of the ideas from surgeons, put a sign on the wall indicating the expiry date of vials. Include vials when you're doing stock takes. Ensure a stock rotation once on receipt of deliveries. Checking clinic rooms regularly. Ensure that the date's just checked before you take a smear, as you would administering a vaccine or a medicine. Also, one of the things is expiry dates. It may be within date, but we ask that this should be 14 days or longer if the current lab turnaround time is longer. So that's always worth bearing in mind. Record the expiry date in the patient's note and ensure that the patient label doesn't cover the expiry date. And finally, for the mismatch labels, we recommend that you don't handwrite or print forms in advance of the clinic. Check the patient's full name, date of birth when they arrive, and also do checks while during the process, but also ask a colleague maybe to check afterwards as well. Again, as I say, these are probably all things in your eye, but these were things that we collated from as bits of advice, really. And finally, the acronym at the bottom, CARE, check patient's details on arrival, attach ID label to vial, ensure patient checks details prior to leaving, R for review date of previous sample, and E for expiry date of file should always be checked prior to sample collection. Thank you.
Thanks, Richard. Just to let everyone know, we are developing a policy where the practice nurse leads and CCGs will be linking in with people who have rejected samples, just to help put these things in place. So it's being trialled in a couple of areas at the moment, and it will be rolled out across GM in the next few months. So a few more just general updates. Just to be aware that trans men or non-binary patients who are not registered as female on your computer system won't be called for cervical screening. At the moment, the national system can't facilitate that. So the GP practice should make sure that the patients are aware if they need screening, if it's suitable, and should make sure that they're offered it at the correct timescales. And please make it clear on the request form if you are taking a sample on someone who's registered as male, that they do require a sample, otherwise the lab might reject it because they might assume that you've mislabeled it. As Richard mentioned, there is going to be a replacement to Open Exeter, which will be launched on the 31st of August. It's going to be a web-based system, and everyone who uses it will need a smart card. So that's any admin staff that complete your PNLs or any sample takers within your practice, and they'll all need a smart card with the correct permissions. So currently, GMSS, who administer most of the smart cards for Greater Manchester, I'm in the process of contacting all the CCGs to make sure that practices have got all their staff with smart cards and all with the correct permissions. There will be training available for the new system. It's not available yet, but as soon as it is, it will be circulated widely. You can visit this website and sign up for updates, and they will email you updates. They have a Teams session every other Thursday where they it's called Show and Tell, so they show you all the new features of the new system. If you are interested, you can sign up for that. And if you do have any questions, you can email this email address, which is screeningimplementation@nhs.net, and that will get sent to the appropriate person if you need help with anything. And an update, some of you might be aware of the HPV self-sampling trials that are going on at the moment. I know we've had a few queries into our inquiry line about if it's available and if practices cannot access it. So currently it's undergoing clinical validation trials and a pilot study in London. So in London, they're looking at people who haven't attended, say they were invited, I think it's 9 months, they're 9 months overdue, and they'll be offered a HPV self-sample. So that's just in certain practices in London. And there's also clinical validation, which a couple of practices are involved with in the Northwest. And what happens there is the patient will take a self-swab themselves, and the clinician will do their normal cervical screen, and then those results get compared to see if the swab is as accurate as a clinician taken sample. So this is currently going through trials and clinical validation. It's unlikely to be rolled out nationally anytime in the immediate future, but we will keep you updated on when it does. It's also important to be aware that if the sample is HPV positive, the patient will be requested to go back to their GP for a normal routine sample. So if that's not acceptable to a patient, then possibly the HPV self-sample wouldn't be the best option for them. And then there'd be, if that cervical sample was positive, then they'd be followed up in as normal in colposcopy. Just finally, we've got, you might be aware of the Greater Manchester Primary Care website, where the vaccine passport is held. We've also got a cervical screening page where we're starting to put updates and information so everything's held in one place. We know we send lots of stuff out to you and sometimes it can get lost in your emails. So if you bookmark this website, we'll just continue to update this page with information. And if there's anything that you think that you would like to see on there, please do let us know and we'll get it added. So thank you very much. If you've got any questions, please put them in the chat and me and Richard will answer them.
Hi Sarah, thanks very much for that. So one of the questions is, are the rejected samples in percentages? Can we have them in percentages rather than numbers?
I haven't got that. There is a very low percentage of the overall samples taken, but as Richard said, it is 350 extra appointments that need to be found in primary care, which is the kind of number that we're looking at. But yes, as a percentage of samples taken, it is quite small. We're just trying to reduce the number of extra appointments that primary care have to offer out, really.
Thanks, Sarah. And the other one is, can you share a copy of your top tip slides?
Yes, we've got it in a Word format, so we can definitely get that circulated, and if you want to stick it on your wall or however you want to use it, then we can do.
And I think that's all the questions, Sarah, that I can see anyway.
If anyone else has anything else, please pop it in the chat and we'll get back to you. You're on mute, Leslie.
Sorry about that. Thanks, Sarah. Thanks, Richard and Moira. Thank you. We'll go over now to Shani. Sorry, Shani, I introduced you before. You introduce yourself. That would be great. Thank you.
Thank you, Leslie. Apologies. I could actually hear you. I was in the room when you introduced me. For some reason, my technology wasn't connecting, so I had to restart again. So thanks to Sarah and Richard for stepping in that way, because it can't do anything about kind of computers when they decide that they want to update. So thank you so much for that. So my name's Shani Rafferty-Smith. I'm the System OD and Leadership Lead. I'm based at the Health and Social Care Partnership, and I work across the whole of Greater Manchester Public Services. That includes anyone who's working towards reducing some of those health inequalities across our localities, neighbourhoods, and at system level as well. Just for context, since the pandemic has started, I spent the first part of that at the Nightingale Hospital in Manchester, and then coming out of there, have been really responding to some of the wellbeing priorities that have been emerging during that period. Everything from lots of practical kind of pulling together of information, because what we're mindful of is that there is a tsunami of info out there, and actually it's not a case of putting more provision into place. It's more trying to connect that provision to where it's needed at the time. So we started to put a version of the Greater Manchester Wellbeing Toolkit, and I'll just stick the link in the launch in the chat for anybody who hasn't had a look at that. So we launched it in March, about 15 weeks ago, and have been running support sessions, information sessions, and working with either teams, people in localities, and having open conversations as well about wellbeing, trying to raise the profile and also kind of look at where those gaps are. So please do have a look at the toolkit, and I'm just going to share some slides. Leslie, can I just do a quick time check, because I'm mindful that the timings have just slipped a little bit. So
Yeah, just bear with me 1 minute.
okay.
Yeah, we're fine. We're on time. We're okay. Child health at 1:30. Yeah, we're fine.
Perfect. That's perfect. Thank you so much. So hopefully you should all be able to see my screen. Okay, so in the first instance, what I'd like to do is just ask all of you to read this sentence. I'll give you about 15-20 seconds and count the number of letter Fs in the sentence. Oh, I think I've just lost the presentation. Just bear with me 1 second. Sorry. Not doing very well today, are we? Okay, let's just do that again. There we go, we should be back. There we go. Okay, letter Fs. Brilliant. So how many people saw 3 Fs? If we do this by a show of hands, so you put your hand up. Brilliant. Okay. Some people have seen 4 Fs. Great. How many saw 5? Okay, got a few 5s. And how many saw 6 Fs? Yeah, I can see a couple of people putting their hands up. Okay. So there are in fact 6 Fs in this sentence. We've got the finished, files, and of, so scientific, and then we've got 3 ofs. And the reason I quite like this exercise is because it really shows and demonstrates that we could all be given the same information. That doesn't necessarily connect to any of us because it's a bit of a nonsensical sentence at the moment, but we all pick up different bits of the information. So some people will have seen kind of different numbers of Fs. And the first time I saw this, I saw 3 Fs. And I think this is really important to pay attention to because we can have all the information and support mechanisms out there right in front of us. But if we're not paying attention, we don't always kind of pick that information up. So hopefully this will give just a little bit of kind of food for thought. Okay. So wellbeing for all of us. As I mentioned, I've been working across the wellbeing agenda for a number of years, but specifically around kind of what COVID response looks like within a health and care setting. And when we started kind of getting a little bit of an understanding of what people meant by wellbeing, it got quite complicated. There were lots and lots of documents. People had huge sentences and paragraphs of stuff, and we wanted to keep it really simple because we wanted it to be accessible. So we've come up with a definition that good wellbeing is when we're able to be at our best, whether that's at home or at work. And with those lines kind of blurring between home and work, we think it's really important to recognise that. And the frame of wellbeing kind of falls within 3 spaces. So the first one is physical wellbeing, so supporting us to be at our best from a physical perspective. And we're really lucky in Greater Manchester because we have some great colleagues in Greater Sport and GM Moving who are doing some brilliant work. They've got an active workplaces toolkit. So if you haven't had a look at that, please do check that out. And they're doing all sorts of things about walking, cycling, and other kind of themes to help us as a workforce, but also our communities to stay physically well as much as possible. We've got some of the practical aspects of what wellbeing looks like. So that could be everything from having good cycle schemes, because there's a practicality around kind of transport perhaps not running in the way that we need it to, and TFGM are running bike schemes. So if anybody's looking to host a bike hub or bike library, I think they're calling them, within your neighbourhood or locality, please do get in touch with them, because they are looking to identify points across Greater Manchester, and it's a great opportunity to support all of our colleagues as well. But that also includes things like sleep, and good sleep wellbeing as well, and kind of good sleep patterns. As well as really, really practical things like making sure, well, this was definitely apparent at the beginning of the pandemic, where we had colleagues who were working 10, 12-hour shifts and then still having to queue up in supermarkets. So we actually partnered up with a number of our retail colleagues to make sure that we can kind of get that support in place to help all of us be able to be at our best every day. And then the third area of our definition of wellbeing is the psychological, and we'll kind of focus on that a little bit. But we have got colleagues from the Resilience Hub. We've got a number of different kind of support mechanisms across the system, and I'll go through some of those. What we do know is that good wellbeing means that we are recognised and we're valued for the work that we do. We have the psychological safety in our workplace. We have a sense of belonging and feeling like we're part of a team. And that teaming aspect is incredibly important to individual wellbeing, but also collective as well. And we also have permission to access activities such as this, to be able to support what our wellbeing looks like. And that might be about us being able to attend masterclasses in particular kind of thematic areas. But it also might be being able to take kind of breaks, reducing kind of the levels of guilt if we are stepping away for 10 minutes or so, that we have the space and the cultural permissions to be able to participate fully. And there are some really clear drivers for the work that we've been doing around wellbeing, and I think it's really important to make sure that we do touch on these. So we know that COVID created that urgent need for what wellbeing looks like in the workplace. It was kind of there, but it necessarily wasn't the priority that it is at the moment. We also know that the pandemic itself highlighted the disparity in the offers that were available. So depending on who your employer was, where you are in the system, which locality you work in, kind of determined what you might be able to access in terms of EAP or occupational health, or whether you had wobble rooms because you had a physical site. We're very mindful that there are a lot of disparities across the system, and we do want to bring a greater equity to the provision that's out there. So we're slowly kind of working towards that. We also know that there's been societal shifts around what wellbeing looks like, and that means that there are greater expectations as well. So as workplaces, we do need to respond to some of that, and this has specifically been around mental wellbeing as well, and we'll touch on that a little bit. And of course, from a political perspective, from a strategic perspective, we've got the GM People Plan, which absolutely embeds wellbeing at the heart of everything that it's doing at the moment, and will continue to do so as we move into the ICS. So incredibly important that we not only kind of create the right provision that's out there, but we're not just pushing it out. There is a process by which we're learning, so we're able to continue to kind of evolve those services as they go on. And the reason why all of this is important is because through sickness monitoring, we know that stress, anxiety, depression are continuing to be on the increase. They're the #1 reason why there is sickness absence. And we also know that MSK is very high on the list at the moment as well, so we're paying some attention to that. There's a recent study that was done by the University of Manchester across health and care workers, which is suggesting that there is also a small percentile increase in suicide ideation, which doesn't necessarily mean that somebody is actually putting plans into place, but they're certainly in a space where they're thinking about what life might be like if they weren't here. So we do need to get comfortable with that conversation, or at least be able to confidently have that conversation, because for those colleagues that might need support because that's where they are at the moment, we don't quite have the cultures around us to be able to have that conversation confidently. The other kind of really important factors that we've got is our fatigue and burnout. I don't think it's a question of whether people have fatigue or whether they are feeling that kind of that burnout element. We know that it's there right across the system, and we do need to pay attention to that. And the reason why that's important, apart from that individual kind of well-being, is we also know that it can impact on good decision making when we're against it. There are, and we've got capacity issues as well, so we do need to pay attention to that. And that retention of colleagues is a really important one. There's lots of discussion going on into how we attract new colleagues into our workforce, and we of course have a retirement profile that's probably as creative as I've ever seen it, to be honest. So you know, people are making lots of different life choices at the moment, partly as a result of reflecting on where we've been over the last year or so. And while there's lots of conversations going on about what recovery looks like, those conversations generally tend to be anchored from an operational perspective, and are being had at a very high overview level angle of what recovery might look like moving forward. But of course, for many of us who are still kind of right in the middle of it, on that front line, still delivering services, we're not able to quite see or feel what the kind of that last stretch of the pandemic response. So we do need to be mindful that when we're talking about recovery and it's anchored from an operational perspective, that we do need to remember what people recovery might look like as well, and start building that in from now. And of course, the reason why that's really important is because if you cast your mind back to last March, we all immediately just jumped into that response, that operational response at the speed of a sprint. But of course, we're not running a sprint, we're running a marathon, which means that that kind of longitudinal approach to what we're doing is going to start having an impact. And of course, people are feeling stressed and overworked at the moment, which we do need to pay attention to. And compassion fatigue is something that keeps coming up again and again. And we're starting to look at what we might be able to kind of put into place to explore that and have discussions around what that is. It's also really important to remember that this is not about a one-size-fits-all there is a huge tsunami of offers out there, and what we're trying to do is make sure that we retain the diversity of those offers, because each of us need something different, reflecting our circumstances, reflecting our lenses of how we see our worlds, our workplaces, etc. So when you're thinking about kind of what that provision might look like from a wellbeing perspective, please do be mindful that actually everyone does need something slightly different. And I've already mentioned that people under stress don't respond very well to anything really, because over time, and particularly decision making, that cognitive ability to be able to make good decisions does suffer, and there's lots and lots of research into this. And part of the work that we're also doing is we're trying to look at what are we learning at the moment in terms of this response period, and how can we embed some of the good stuff that we've got into the overall wellbeing cultures as we move forward, because we will come out of this period at some point. So what we want to do is try and retain the good stuff as much as possible. And all of this is incredibly important because you'll see the stress bucket that's on your screen at the moment. More often than not, it's not about a big protracted incident that causes levels of stress and anxiety. It actually tends to be lots and lots of small things accumulating in that bucket. So that top tap will continue to drip. And what we tend to find is that it will be a mixture of work stuff and life stuff. So everything from changes in IPC regulations, we have to keep up with that, to patient abuse, to I don't know, shift in legislation, a new booster campaign, all sorts of different things start layering on a day-to-day basis. But it also might include things like car insurance renewals, and somebody was talking about this in another session where they were saying, well, I let it auto renew last year, but I know that I need to just sit down for 15 minutes and do it, but it just feels that one extra thing that I can't think about at the moment, but it's causing me a lot of stress, and my renewal date's coming up. So it might sometimes be the smallest things that actually create some of the biggest impact. But of course, that tap at the top isn't the tap that we need to focus on, because we can't necessarily stop some of those things kind of accumulating in our bucket. What we can do is focus on the tap at the bottom, which is actually where our wellbeing strategies come from. So how are we individually developing the strategies that we're using that work for us, each of us individually, to relieve some of that stress, and really focus on good psychological well-being. Now, that also might be that you're thinking about it in terms of your team, and the people around you as well. So they'll all be take slightly different approaches to what that might look like. We'll explore some of that at the moment. Okay, so if you haven't had a chance to have a look at the toolkit, I've just seen a question. Yes, the slides will be shared. I'll make sure that they're circulated around. So I think Roisin's just asked that. If you haven't had a chance to have a look at the toolkit, it's broken down into 3 areas. The first section is about looking after yourself. And in many ways, this is all good common sense stuff that we all already know. It's about the quality of our sleep, the water that we drink, the food that we eat, the exercise that we take, and really building that wellbeing strategy for us as individuals, to make sure that we're looking after ourselves. The second section, I think, is incredibly important because it's actually about how we look after others, so the people around us. So you might be a line manager or team manager, you might be kind of leading a number of different teams, but you also might be supporting the peers around you. So you might be part of a team and you're the person who kind of just takes a little bit of a lead of checking in with others, making sure they're okay. There are lots and lots of tools and tips and templates and kind of information that will help you do that effectively. One of the biggest things that we heard when we started doing this work last year was that people wanted to ask, people wanted to help, but they didn't want to say the wrong thing, and they certainly didn't know how to start some of those difficult conversations. So we all know the are you okay, and asking it twice. But it's the follow-on questions that people struggled with. So we have, for example, got a template of some sample wellbeing questions that you might want to ask. That's all based on good coaching evidence. So it gives you a few pointers of the kinds of things that you might want to question. And then the third section is responding to needs. So I've mentioned this already. There's lots and lots of brilliant provision out there to support people, either directly through your employer, or you can access it autonomously. So you don't need to get a referral you can do it directly. Some of that provision is where you actually do a face-to-face or you talk to people. Other provision will be online. So do have a look at that. Make sure you just kind of are aware of what's around there and for you. And it might be for yourself, but it might be for your colleagues around you, but at least you know what that information looks like. Some of that provision is also accessible for our residents, our community, so it might also be helpful to know about that. So, for example, the National Domestic Abuse hotline or the GM bereavement services are there for lots of different people, and you kind of get guided through that. The two things I would like to draw your attention to, which are in the toolkit, so please do have a look, is the psychological first aid and the suicide prevention training. They're both free. They both take about 20 to 30 minutes. They're hosted by FutureLearn. Please do have a look at it. Please encourage all of your colleagues to take part because it's there as a good, quick access that people are able to just kind of gem up on their own knowledge and information. And of course, doing all of this, it's become apparent that actually sometimes the most obvious things do need reiterating. So we have put together a little bit of a pandemic guide to taking care of yourself and your teams. And I think it's always really useful just to kind of touch base on this. So please do remember to be kind to yourself and to others. Pay attention to your behaviours and the kindness and compassion that you might show towards others or extend towards others. And give your expectations a break. This period that we're in isn't about perfection by any shape or form. Good enough is good enough at the moment. Give yourselves a break, I think, is what I'd suggest. Proactively do manage your anxiety and stress because we're all under it in some way, shape or form. So think about what is included in that wellbeing strategy for you and how you put that into place. There's lots of evidence, for example, from our colleagues in emergency services that kind of the peak and the trough of responding to blue lights means that actually there's a lot of people who kind of have, their adrenaline and the cortisol kind of all kicks in and the dopamine kind of sets in as well. So we get a lot of people who use extreme sports and adrenaline sports to be able to help manage that and counterbalance some of that. So and that seems to be quite an evidence-proven thing. So just have a think about kind of what works for you. Do socially distance. I know the rules are changing as we speak, and everyone's kind of taking their own individual stance on this. But please don't isolate yourself socially. Please do make sure that you maintain those social connections and the things that feed you as well, because talking and connecting with others is a really big part of this. Keep calm and please do not always carry on. So this isn't about waiting till you get to that crisis point and then are just ready to keel over before you put your hand up and suggest that you might want some help. We are talking about this from a management, a preventative perspective. So how we manage our well-being is incredibly important. So do think about kind of if you're feeling like your plate's just a little bit full or things are just feeling a little bit overwhelmed, then do please access some of that provision and take a flexible approach to what's going on around you. And I love this one, feed your heart. So do the things that really kind of feed your passions and kind of keep you going. For some people that might be going out and seeing friends. For other people it might be music, it might be food, it might be all sorts of different things. And what are the things that you absolutely love that you've just not been able to do, and find spaces to be able to do that, because that's the stuff that keeps us really human. And keep looking up, because this period will come to an end at some point, and we are in a bit of an evolving picture at the moment, so we do need to take heart in some ways and pay attention to the fact that we will come to the end of this. So one of the things that I talk about in the support sessions is this brilliant tool, which I use when I'm doing one-to-one conversations, which is by Pip Wilson. It's not new by any shape or form, and it's called the blob tree. And I like this one in particular because actually all the blobs on the tree are numbered, so it's really easy to kind of refer to. So if we think about the fact that we all have mental health, and we all fluctuate with that mental health as well. So, some days we might have a good day, some days we might not be so great. I think it's really important to think and reflect on what does a good day look like from a wellbeing perspective? What kind of behaviours do we start projecting? How do we approach situations? How do we participate in conversations? So I will guarantee you that if you're having a good day, you'll be a lot smilier, you'll be a lot more open to conversation, you'll be a lot more energised and energetic, and that in itself will feed into the people around you. So, you know, smiling is really, really infectious. Likewise, if you have a bad day, your mindset might be a little bit more closed. You might scowl a little bit, you might be shorter in your sentences, which means that actually people might be a little bit more standoffish with you because they're also perhaps kind of in those spaces as well. And it is really important that we do reflect on where we are on this blob tree. And I'm not going to ask anyone to kind of put their hands up and tell me where they are. I've decided I'm a number 10 today, by the way, apart from the fact that my tech problems have just perhaps challenged me a little bit more than I anticipated. But it is really important that we're aware of what we're like when we have a good day as opposed to a bad day, because it then helps us reflect on what's going on with other people, and how we can get the best out of people. So if we agree that good well-being is being able to be at our best, one of the things that we do need to focus on in the workplace is actually how do we support people to be at their best, and how do we recognise that and give each of us the compassion in the space to be able to operate in the best way possible on any given day. So do have a look at that. The slides will have a link in them, so you can download that and have a look at it. And Pip Wilson's brilliant. There's lots of different versions of this, so do have a look. And I think it's also really useful to hopefully you'll all be aware of the 5 ways to well-being, because it's still really relevant and it's still really true. This isn't new again, but it's there, it's good practice. And I think the ones that we have been focusing a little bit more on are the stay connected, the take notice, be active, and give to others. And in particular, the give to others. You know, we've seen that in our communities with the rise of mutual aid groups and the continuation of the support within our communities, but also kind of people just stepping up and doing extraordinary things that they never thought that they'd be able to do. So whether it be formally within a secondment arrangement, or people have joined different teams to help with that response to the pandemic, or it might be that people taking a different kind of role within their home or community lives. The one thing, the one area that does kind of keep dropping, or we're not perhaps paying as much attention to, and it is worth focusing on a bit more, is that keep learning. So there is a balance between that formal and informal learning. So for example, if you are somebody who has been on secondment or you've joined another team, if they come back to you and your team, then ask and pay attention to what other skills and capabilities might they be bringing back, and how can you then embed that into the way that they deliver their roles. I am hearing lots and lots of stories of people who are kind of going back to their substantive posts or their teams, and then are continuing as they were before, but not necessarily being able to utilise kind of the skills that they've developed. And of course, it's great that we've got lots of formal offers and opportunities to keep developing our skills and look at what progression looks like, but they are fewer and far between. So we do need to pay a little bit more attention to that. And I know, for example, that with the care programme, which is a really good example, there are cohorts of nurses who are going through that, and hopefully that will continue. But how do we keep cascading some of that learning? And so the other kind of really good resource that we have in Greater Manchester is our colleagues at Public Health England have been working with the Good Employment Charter and have produced a mental health toolkit for our employers. This has got lots, again, of great kind of tools, tips, and we've been working alongside each other. So they launched at the same time in March. And it's worth just having a look at this because it's got lots of case studies and lots of great work in there. So it's great to get a bit of an insight as to what other people are doing about some of their approaches. So I think I've kind of touched on this, but how do we create the shifts in our workplaces, I think, is one of the big questions that we keep coming back to. It is very critical that we pay attention to the fact that we are working very differently at the moment, and our expectations are very different. I had a discussion with somebody yesterday where they were expressing that there was an unsaid assumption that because they weren't commuting and working from home, that commuting time was now officially game work time. So and I don't know how true that could or should be, but we do need to pay attention to kind of the behaviours and the patterns that we're falling into in the workplace. We know that we've got a legacy of what well-being looks like. It has almost come from that punitive approach. So, you know, you'll be very familiar with this. You know, if you have kind of 1 sickness absence, then you might kind of get a letter, you might have a conversation at 2, you might be put into performance measures at 3, who knows, depends where you are and the kind of work that you're doing. But what we're really trying to do is just shift that evolution of practice and make sure that as our services are evolving and we're embedding kind of digital technologies and everything into the kind of the efficiency of the work that we do, that to improve our services, that we kind of put the humanness back in all of that. And we do focus on that physical, that practical and that psychological approach to what wellbeing looks like. Okay. So for those of you who love to read a good academic paper, there is a paper called Pursuing Happiness, and there's an element in there which talks about the happy pie, and I quite like this because actually what it really kind of shared with me was how much of this is in our gift. So it acknowledges that 50% of our happiness is determined by our genetics, what we inherit, the way that we were brought up, the legacies that we have. 10% are circumstance, so our socioeconomic kind of capabilities, where we live, how much green space we have around us. And 40% is what we do. So the choices that we make around the sleep that we have, the food that we eat, the levels of exercise, the amount of alcohol that we consume, all of those things are our choices. So I like to think and choose to focus on that 40%, because if that's within all of our gift, then we have the ability, regardless of kind of the frame that we come with, to be able to make a significant impact. So do have a look at that. And again, the link is in the slides. One of the really helpful tools that we have in the toolkit is called a check-in, check-out process. And this is very much kind of like a day-to-day, how do you reflect on what your day's been like? How do you bring closure to it? And also, how do you extend that to your colleagues? We're all very used to doing kind of like operational handovers, technical debriefs, whatever it might be, but we very unfrequently kind of focus on the human element of all this. So please do have a look at that and pay attention to how you might do that for yourself and also with your colleagues as well. And I'll skip that discussion because of time. A couple of things I do want to flag before we get to a close is kind of how we set our boundaries. So what's become really apparent is that blurring of home and work life and the expectations that are kind of just embedding themselves into our cultures and our behaviours and practices that we do need to be very conscious about. So please do pay attention to that. It's really easy with the technology that we have to have a laptop or a phone pinging in the background and it kind of impinging on our home life. So we do need to be aware of that because we do need times to kind of decompress and reflect and also kind of have a break. By the sheer nature of the work that we do tend to just carry a little bit of the, and I've used the word trauma here because I think that is the right word, of the people that we support or that we work alongside or the patients that we kind of carry. Now, this isn't about clinical trauma by any way, shape or form, but this is about kind of that accumulative kind of hearing a kind of day-to-day kind of the struggles and the impact that the pandemic has had on people and also their frustrations as well, and how that might kind of, you know, we end up carrying some of that. So pay attention to that. And that's kind of aligned with some of the guilt and some of the resentment. That might be everything from, you know, somebody's got it a lot better because somebody had a lockdown and somebody didn't have a lockdown. There's all sorts of different reasons that we might have that guilt. What I hear most often is something around when colleagues are needing to isolate or kind of be able to take space. There's an associated guilt with that because actually the work still needs to be delivered and then other colleagues are picking that up. So it is worth paying attention to that. And reflecting on kind of the reality and the perceptions of what this looks like. What I'm mindful of, and this is coming back quite loud and clear, is that we have lots of middle managers across our system who are absorbing kind of what's coming down from a strategy or a leadership perspective, are trying to lead teams and protect them at the same time, but end up kind of holding and consuming a lot of kind of the stresses and the anxieties. So we do need to pay attention to some of that, those isolating positions that our leaders and our middle managers are finding themselves in. And you might be one of those yourself. So, you know, do please pay attention to that. Okay, so technology is a really important one. We have rushed towards the use of technology. and put it into place to make sure that kind of we've got the services and the provision that is needed to deliver what we need to. But actually we do need to be very purposeful and conscious about how we're delivering that. So if you're in a position where you are commissioning kind of appointment systems or you know, whatever it might be, please pay attention and build in some of the human elements of that. So build in breaks in between appointments, make sure that we're not encouraging people to kind of sit in front of a screen all the time, and that we are building in some kind of human contact. And there's some really interesting examples kind of coming through general practice at the moment that we do need to kind of pay attention to in terms of those tools. And the there we go, the healthier leadership framework, which has been, oh, apologies, that's kind of shifted. Let's go back the other way. There we go. The healthier leadership framework, which has been developed with our colleagues at the Leadership Academy, is worth having a look at, because what that does is it creates a bit of a benchmark about what good looks like. So it's just launched earlier this year, so please do download that. Again, the links are in the toolkit and the slides, which I'll send over. And it might be worth the spaces that you're working in just kind of paying attention to kind of those approaches. And finally, I just wanted to kind of touch on, we've been talking a lot about the preventative stuff, the stuff that's within our gift, the actions that we can put into place to really inform those good wellbeing strategies. But what I do want to touch on is when we should be asking for help, because I think that's really important as well. And more often than not, when I go through this, you know, there's always that one person who sits there and goes, I hadn't really thought about that. So if you're experiencing high levels of distress, you might need to ask for some support or some help. If you're unable to focus at work or at home, you're not able to perform daily activities as well, you're struggling to make decisions with things that you actually would have found really easy earlier beforehand, or you're having poor sleep over a long period of time, you might need to ask for help. If you've significantly changed your behaviour or increased your intake of alcohol, social media, fitness is another one, or food or anything, please do pay attention to those behaviours, because they might indicate that actually there's something else going on and you do need to pay attention. If those around you, whether it's your colleagues at work, people at home, are noticing shifts in your behaviour and they're saying to you, I'm a little bit concerned, just wanted to check in, then do pay attention. Please don't dismiss it. We're all very quick to kind of go, I'm fine, I'm okay, but do please pay attention to that. And if you're worried about your own ability to keep yourself safe, because you'll know it yourselves well, and you might not kind of verbalize or articulate it, then do ask for help, because there's lots and lots of help out there. And again, I would want to reiterate that you can either go through your employer or the workplace that you're in, or you can access support directly as well. A couple of things just to flag up. We have got the Resilience Hub. It's there. It's been commissioned for all of us to be able to access. So please do. You can do it through your line manager, who can put a referral in for you for screening, or you can do it directly. In some occasions, I've actually been putting some referrals in as well, just to get some initial screening for managers who perhaps just don't feel confident enough and don't feel like they're bad enough to be able to ask for help. So we'll kind of link that up. So I'm more than happy to do that with people. And what I'll also include in the slides are a series of hyperlinks to all the different support that I've spoken about. So I'll pop that all in for you. So just to finish off, what I would like to do is, because every single room I go into, I do challenge and ask people to put some calls into action, is just to have a bit of a think about, are you clear about what your wellbeing strategy looks like for you? What do you want to achieve for yourself? And likewise, what are you wanting to achieve for the people around you that you're supporting, your teams, your peers, and the people in your workplace? Please do pay attention to what you've already got. More often than not, if we're not paying attention to support mechanisms around us, we might be surrounded by lots and lots of things and just not be aware of it. The most effective thing I found is our bulletin boards and QR codes, so putting posters up and information pieces. And the QR code, very simply, we've all got smartphones. You just scan the code and it takes you immediately to that provision. So we've been using that quite a bit as well. And you'll find that in the toolkit also. Have a look through the toolkit, figure out what works for you, try it out with your colleagues, and it is a bit of trial and error to find the right thing, so please do have a go at some things. So I've mentioned check in, check out, but we've also got a buddy system that seems to be working really, really well. So some colleagues are calling it tag, so that kind of opportunity to check in with each other. And do remember to look after yourselves, keep things simple, and cumulatively all of that will create an impact on your well-being. Okay, so I think I'll just stop sharing, and if there are any questions, I've seen the chat but I've not been paying attention to it. If there are any questions, more than happy to pick them up.
Oh, Jenny, thank you so much. We have got quite a few hands up. I don't know if some of them are legacy hands, or so can you just have a look at your hand if it's definitely a question for Jenny and not about the breakout room. The breakout room and all the slides Jenny will share, but if any specific questions, we've got about 2 minutes to quickly ask any. So, hands, Jill Roberts, have you got a question for Jenny? Or is it a legacy hand? No, it's gone. Simone Dawson, are you a legacy hand? Kerry as well. Kerry, have you got anything to say?
Kerry Porter.
Yeah, that Kerry Porter's got a hand. No, it's just got Kerry Guest, so I don't know Kerry.
Oh, no, not
Unless
me.
there's 2 of you. I'm Jeanette Taylor. Any questions or just legacy hands? I know we're running a little bit behind, aren't we?
I know, apologies to Claire, who's setting up all the
No, right. I presume they're all legacy hands as no one wants to talk to us.
No
Thanks
worries.
so much, Jenny. It's been really interesting again. I get so much out of it every time you come on.
Oh, thank you, Moira. And good luck and enjoy all your breakouts.
Thank you.
Thanks,
Bye.
Jenny. Thanks very much for that. That's great. Thank you.
Thank you.
So some really good information there from Jenny, and I'd really urge you all to look at that toolkit and take up the offer of those sessions that are available from that. Let's move on. Next on the agenda is Helen Benyon. Helen, are you with us?
Yes, I am.
Yeah. Okay, thanks, Helen. Sorry we're a little bit late.
That's no problem.
Thank you.
My presentation is probably a bit shorter than the time frame anyway, so probably gets us back on track. Oh, someone sharing for me, thank you. So I'm Helen Benyon, and I'm one of the screening and immunisation managers in the Greater Manchester Screening and Immunisation team. Thank you very much for your time today. My presentation is just around highlighting some lessons learned from some recent immunisation incidents that are good to share across the whole area. So could we move it on to the next slide, please? So for anyone that isn't aware, just a quick overview of what our role is within the management of immunisation incidents. So first of all, we can provide advice on how to manage an immunisation incident, so big or small. If something's gone wrong within either an immunisation itself or within the cold chain, contact us and we can give you advice on how to manage that incident. For more serious immunisation incidents or cold chain incidents, we can oversee the management of those. So larger scale where there might be more patients involved or a larger scale revaccination programme is needed, we can oversee the management of those. And then one of our key roles, and one of the reasons I'm here today, is to observe the trends in immunisation incidents and look at how we can prevent those incidents happening again in the future. And all immunisation and cold chain incidents that occur should be reported to us at the email address that I've included there. And we have a standard incident form that we ask people to complete once those incidents are reported to us, that you can use for your own internal incident review processes, root cause analysis, that kind of thing. Can you move to the next slide, please? So just a quick overview on a couple of cold chain incidents that we've had recently. That a couple of practices have been happy for me to just share a quick overview of. So we've had a couple recently where the actual cold chain breach itself has been an unavoidable cold chain breach, so due to power failures or the fridge failures, so not due to things that are more avoidable, like the fridge door being left open or vaccines being left outside of the fridge. But in both of these incidents, the time frame was complicated by incomplete temperature recordings prior to the breach. So in both those incidents, we've had to offer revaccination to a lot more patients than potentially would have needed to be revaccinated if the temperature recordings were complete, because we had no way of guaranteeing. Oh, someone's saying I'm very quiet. Shall I move closer? Is that better? I'll shout. We had no way of guaranteeing when that breach actually started. So for some patients that potentially were not in receipt of a vaccine that was affected by that breach, but we've had to offer revaccination again. And as I'm sure everyone on the call will understand, that causes a massive amount of stress for those parents, because a lot of those patients involved were either babies or young children. But it's also a massive amount of stress for the staff involved, who've had to contact, you know, in some cases 50 odd patients and ask them to come back to be revaccinated. So just really to highlight the importance that, you know, temperatures need to be recorded at least once a day, and they need to be documented. So that's how we look back when there is a cold chain breach, to see when that breach occurred, how long it lasted for. And if there isn't a documented record there, then we have to, like anything else, if it's not documented, it didn't happen, and we need to go back even further. Another important point to highlight for some recent cold chain instances around the servicing of your vaccine fridges. So the Green Book advises that your vaccine fridge must be serviced at least annually, and you need to have records of that. Again, that's going to help in the event of fridge failures, that we might be able to identify that actually we know for sure when exactly a fridge was working according to the manufacturer. So that's really important as well. And one last thing to highlight, particularly around cold chain incidents, is that everybody with responsibility for temperature monitoring must be aware of how to respond to out of range temperatures. So again, we've had a few incidents recently where the temperatures have been recorded, but they have been out of range. But the person has been very diligently recording them, but that information hasn't been acted on. So again, we've had vaccinations continuing during that time that we've then had to look at recalling patients for, because the temperatures were actually out of range. Next slide, please. And then just as part of this cold chain instance, just wanted to highlight some really key points around data loggers. So hopefully quite a lot of practices will now be using data loggers as a secondary temperature recording device within fridges. And data loggers are particularly helpful when it comes to cold chain breaches. So if you've recorded your fridge temperature recording at 5:30 on a Friday, there's a power cut over the weekend and it's not picked up until 8:30 on a Monday morning, a data logger is that really key piece of information to tell you how long that breach lasted for, because it might well be the power only went out on Monday morning at 1 o'clock and you've got a 7-hour breach rather than a 36-hour breach. So they're really, really helpful to help with those kind of incidents. They need to be set to record at regular intervals to be able to help with that picture. So we recommend around 10 minutes for each recording interval, but certainly at least every hour they need to be recording. And again, just a few things to share from some recent cold chain instances. Some practices have had a data logger in the fridge, which is great, but we've had a few where the data logger has been in the fridge but it's run out of battery, or the memory I've put has not become full but has become full, so that it stopped recording because it's run out of space on its memory. And to be sure that the temperatures recorded are checked at least once a week, because this is your backup, and sometimes your data logger will pick up issues with the fridge that might not be necessarily apparent. So we've had a cold chain incident recently where the fan had broken in the fridge, but where the temperature probe was for the actual fridge itself was recording as an in-range temperature, because it was in a different part of the fridge from where the fan was based. The fridges had become uneven in temperature, so one part of the fridge was much colder than the rest. So the fridge was showing fine, but the data logger showed where the problem was there. So actually this fridge has been going out of range. So they're a really good backup for your general temperature recording as well. Next slide, please. And then just a few more general immunisation incidents to highlight. So one particular theme that we're looking at the moment is around checking the actual immunisation history of the child, rather than the clinic lists that are coming from the child health systems. We have been picking up some data errors within the child health system, and that might be for a variety of reasons. Either the information supplied to the child health hasn't been correct or hasn't been entered correctly, or there's been a delay in that information either being sent or entered into the system. So it might actually be the immunisations that child is due at that time. So it's really important to check either your own clinical records or the child's red book prior to any delivery of immunisations, to be sure that they are receiving the right ones. And it's also particularly important for some of our families who don't necessarily stick to the immunisation schedule as it is. So, you know, they're coming for what you think is the 16-week immunisations, but they're actually way behind, and it's their 12-week immunisation. So really important to check that each time. We've again had a few incidents recently of vaccines that were out of date. So it's just a reminder, particularly when there might be as many people in practice as there normally is because people are working from home, or that the stock is regularly rotated to make sure that vaccines aren't being kept in there for longer than usual, and then people aren't realising that they're going out of date. And then just a couple of final things to highlight around checking the age of the child prior to administration. So for PCV, with the change of the PCV schedule from the 2+1 schedule to the 1+1 schedule, you'll know that PCV should now be given at 12 weeks with the second primary immunisations. But it's really important that that immunisation is not given before 12 weeks, even if it's a couple of days before. The guidance is very clear that all the research that has been done into changing that schedule is based on a child receiving it at 12 weeks, not 11 weeks, 6 days, 5 days. So really important to check that child is 12 weeks before you administer, because if they're not, the guidance is to repeat them, so they'll end up having an additional vaccine. And again, for the 1-year immunisations, MMR, I think the guidance is very clear around not giving it before the first birthday, but it's equally important for the other immunisations given at 1 year as well to not give them before that child is 1, because if they are given before 1, again, they will need to be repeated. And I think that's it mostly for my presentation. Quick whistle stop tour. I've got a final slide just to highlight just a couple of really good resources around vaccine instance. So the first one is the vaccine instant guidance, which is your kind of Bible when it comes to any cold chain or immunisation instant. There's a wealth of information in there about how to respond to different types of vaccine errors and the recommendations for revaccination for each individual vaccine as well, about when you can repeat them if they are needed. So if you aren't aware of that guidance, I would really advise you to go and have a look. It's long, so you might want to dip in and out of it, but it's a really good resource. And then just to highlight a couple of these vaccine specific resources as well. So there's general information for each of the vaccines within that guidance, but for most of them, they'll have like a kind of question and answer section at the end, which is, you know, around errors in administration. So I've given it at the wrong age, I've given it in the wrong schedule, and often the answer is there to kind of what you need to do. So if you've got that patient in front of you and you realise you've made your error, you might be able to find the guidance there. You should still report it to us, but it might just help you in that moment to be able to find what you need to do to correct that error in administration. And so all the links are in there, and hopefully you should just be able to click out of the presentation. And that's it. Thank you.
Thanks for that, Helen. That's really good. Some useful information there. We've got a number of questions in the chat. Is there a way that we can send these to you and we can get the answers to everybody that they're asking? Yeah,
if people want to send them to me,
only because we're pushed for time. I know really you'd want to answer the questions, but we are pushed for time. We need to make that 2 o'clock slot quite quickly. But we can do that. And just to remind everybody that the whole of this meeting and the breakout rooms will be recorded, so you'll be able to access them again on the Primary Care Careers website, so you'll be able to watch it again. Okay, thank you very much, Helen. Thank you. Thanks for your time. So just moving on then, so the next part of the agenda, over the coming months we'll be highlighting the tremendous work our COVID vaccination training pods have been doing in Greater Manchester. And today I'm delighted to introduce Catherine Arrowsmith. Catherine is the lead nurse at Bolton GP Federation, and she's here to discuss her role and the inception and progress of the training pod in Bolton. Thank you, Catherine. Thank you.
Thanks, Leslie. Good afternoon, everybody. Thank you, Leslie and the team, for inviting me to speak today. As Leslie said, I'm the lead nurse for Bolton GP Federation, and I'm also the training pod lead for Bolton, employed by Greater Manchester for 1 day a week. Claire was supposed to be sharing my slides. I don't know whether Claire's there.
Sorry. I am. Karen's sharing it while I'm moving people into breakout rooms.
Okay. Are they there, the slides? I can't see them.
They're not there yet. Just bear with us.
Okay. Sorry. Getting ahead of myself.
Just bear with me a second while I just bring them up. Thank you.
Okay. So I'll go to what should be my second slide anyway, ready for when they're up. So in December last year, we commenced training in readiness for the rollout of the COVID vaccines and to support immunisation programmes across Greater Manchester. The training was a train-the-trainer model and has since been cascaded to others certainly within the Bolton vaccination service, and I imagine across Greater Manchester alike. Initially, a lot of the training was in-house to develop our own team here in Bolton, mainly looking at training reconstitutors and vaccinators who'd returned to Bolton to help us out with the vaccination programme. Thank you. Initially, everybody in the workforce was particularly nervous about dealing with the Pfizer vaccine, and the reconstitution of that vaccine was quite daunting initially. So it was imperative that everybody got the same standard of training across the board. Next slide, please. In January, Moira and I held our first ever peer support group. There were just the two of us back then. And we have since developed into a group of, we were 9, we sadly lost 2 recently from Bury and Tameside and Glossop. But the peer support group meets once a month, and we discuss how our training sessions have developed and progressed over the months, and also share tips on how we can improve them. And it's a really excellent group, and I personally have taken lots of support from the team there. So yeah, it's good to see what's going on in different areas, and also good to see that we're facing similar challenges across the board as well. Next slide, please. So an essential part for me as a training pod lead is having access to the Greater Manchester COVID-19 digital passport. This gives me the assurance that everybody that comes to our training pod has completed the e-learning for health and the digital passport. And it tells me at a glance if this is a registered healthcare professional with a valid and up-to-date registration, and exactly which areas of the vaccination programme they want to work in. We have registered and unregistered people coming to the training pods and wanting to become vaccinators. Excuse me. And from an employer's perspective, again, having the assurance that all the vaccinators coming through have completed the GM passport, it's so valuable to us because it saves me so much time. And it's just giving me that quality assurance that everything has been done and all the boxes are ticked and certificates are processed and uploaded correctly. Next slide, please. So as I said, we can view the training record as a training pod lead. I view them on a regular basis. I look at who's coming to my sessions and check that everything is completed, and what level of training they require, whether they're excuse me, a return to practice immuniser or somebody completely new to vaccinating. But again, it's really important that we've got that background check that's already been done, that all the mandatory training and BLS, etc., has been completed prior to them coming to us. And also another really good point from the training record is that the individual can choose which locality they want to work in, and that gives us a guide as to whether they want to stay with us in Bolton or go across to GM. They can also, they have the option to get on board with Lantom as well when they're using the GM passport. Next slide, please. So in Bolton, to date, we've had around about 50 trainees come direct via Greater Manchester. We've had others come through via the CCG, and we've had countless staff come through our primary care networks in Bolton that we support. Our training days are planned to coincide with our clinic days. Primarily now we're working Wednesdays, so that's working really well. The trainees are invited to the training pod, and we do a practical session which lasts about an hour long. And during the session, I've found through feedback over the months that the most people get out of these sessions is actually doing every aspect of the process themselves. So we go through from accepting delivery of the vaccine, what the vaccines look like, how they're stored, talking about record keeping, maintaining cold chain. And then we go on to reconstitute the Pfizer vaccine. And people find this so valuable. And I think this is an ideal opportunity for people to maybe pinpoint where it's possible for errors to happen in reconstitution. And it raises the awareness around how important that process is in itself, and a vital step in the whole of the vaccination programme. So once we've gone through reconstituting the vaccines, we look at welcoming patients into our virtual pod at this moment in time, and we talk about gaining consent, different forms of consent. And then we go on to more practical aspects again, and new vaccinators are given the opportunity to practice with a rubber deltoid, and it's quite useful sometimes to have a completely new to vaccinating person and a more experienced person, because we can help each other to gain vital experience that way. And then once people feel comfortable with the rubber deltoid and the practice they've had, we will then go over to the vaccination clinic to get some real life experience. Next slide, please. So going back to the trainees briefly, we've had we've welcomed trainees from a wide range of disciplines, and as I said, some of the trainees have never vaccinated prior to coming to the training pod, and some have been returning to practice to support the pandemic, which has been wonderful. And there's been other people who've been working in a different role rather than a clinical role, and they want to come back to support the programmes. I've put up a list there of the many different disciplines that we've had through the training pod. I'd noticed about 5 minutes before I started presenting, I'd missed off optometrists, and we've actually had 3 optometrists come through the training pod, and they thoroughly enjoyed the sessions as well. So it's been fascinating meeting all these different people who've wanted to become vaccinators. And more recently, we've changed our model in our clinics in Bolton. So we are involved in non-registered healthcare workers as well. So obviously this means that these people are not able to consent during the vaccination programme. But as we had to develop models as we went into the surge vaccine programme, we needed to have more vaccinators. So we find that at the minute, if we have a clinic, we'll have just one vaccinator who's unable to consent working alongside other consenter vaccinators. But when we're doing a huge surge vaccine session, and as we have coming up next week, we're going back to the ESSA Academy to deliver, probably thousands of second vaccines there, we'll have one designated tent with unregistered vaccinators who will have consented patients directed to them. Next slide, please. So all the new vaccinators and those returning to vaccinating after a prolonged interval are required to complete the competency assessment document, which is on the slide now. This is to evidence their formal evaluation and sign off for their clinical competencies. We work through this assessment at the clinics when we've gone down to work with the patients themselves. Trainees observe a minimum of 5 people being vaccinated, and if the trainee then feels comfortable, they will be then offered the opportunity to start vaccinating themselves, and they will do a minimum of 5 under supervision. Excuse me. This often will continue into maybe 10, however many it takes for the trainee to feel confident and competent, and they certainly wouldn't be signed off until they'd achieved that. Next slide, please. So once the face-to-face training has been completed and the competency assessment has been uploaded onto the GM passport, the team at GM will approve the passport from their side, and then in Bolton, I know then we offer everybody with an approved GM passport who's come through our training pod the opportunity to sign up with us at the GP Federation to come onto our rota group, or indeed direct them across GM wherever they want to work. Feedback has been absolutely phenomenal. Everybody has really enjoyed the one-to-one training, and I think in essence it's the small groups that have really helped make this a positive experience for people, especially over this last 12-18 months where we've had very little face-to-face training. It's been lovely to get back and meet people face-to-face, and it's been really beneficial to all. Bolton GP Fed has got a vaccination workforce of approximately 146 people. This includes vaccinators, administrators, and an operational support team. We have 20 clinical leads and 45 very essential volunteers that support the smooth running of our clinics. On a personal note, without being offered the opportunity to join such an amazing team, I doubt I would have been quite so involved in the vaccination programme. It is an honour to work alongside the training pod leads and the GM team in developing the training pod and supporting our region and fighting back against this unyielding virus. Thank you very much for your time.
Oh, thanks, Kath. That was really useful. I think Dawn's put in, for anybody that hasn't got a COVID passport, the link for you to register. So it's in the chat box, so do use it. And I think Leslie's going to divide us up into our groups soon. This is going to be very exciting, Leslie. So please bear with us. You should all get into the room you've asked for, but we might have some that you don't get in the right room, but all of them are recorded so you can listen to them later. So don't worry if you end up in the wrong room. Just take it as a learning exercise. Over to you, Leslie.
Thanks very much for that, Kath. Some fantastic work going on there in Bolton. I'm sure you'll agree with me. Yeah, everybody who's registered for a room and has done those changes should be directed now by Claire into them. So it'll take a few minutes, and then we'll all be, after that session, be redirected back to the main room. So if you just hold on for Claire, and she'll take us all out bit by bit. Thanks.
I'll start the breakout rooms now.